are right now. We are not done with just the design part of the needs assessment, but what I want to point out is that this is a project that's very community engaged. We try to make all of our products very community friendly, so happy colors, bright colors, positivity. We've had a lot of community input into what the product should actually look like. Of course, we start off with an executive summary, go through a process. What I want to also notice, so every time we conduct a needs assessment, the outcome of that needs assessment, sounds like a dog. Look at my house. The outcome of the needs assessment is to identify priority needs. Priority needs based on what our community is telling us is really important. So back in 2016, the last needs assessment, we identified 4 priority needs: mental health, place-based care, care coordination, and health literacy. What we decided with the 2019 needs assessment in combination and consultation with our community advisory board is that we don't need to pick a whole set of needs. In 2016, we identified these needs. We've been working for 3 years on advancing some of the issues related to these needs. Rather than picking a whole new slew of needs, we decided to maintain the 4 needs from 2016. So we're still working within the domains of mental health, place-based care, care coordination, and health literacy. We group all of our findings from all of the work we did into 4 action areas. These action areas are supported by the Robert Wood Johnson Foundation, and the action areas are community dialogue, building relationships, developing the workforce, and simplifying the path to wellness. And I'll talk a little bit more about these as I go through. As I mentioned, you can't see the entire screen. I don't know how to make you see it, but these are all of the partners that we have in the DC Healthy Communities Collaborative. So we have 5 hospitals across DC. Our newest addition, thank you. And you can go. Yeah, I can go now. Awesome. Thank you. There we go. So these are the members we have right now. It's a really unique collaboration. There aren't a lot of efforts in DC where all the hospitals, community hospitals, come together and work together. We have 5 hospitals. Our newest hospital is HSC Health System, which is now a partner with Children's, as many of you know. We also partner with 4 community health centers as well, and we have 2 ex officio members, the DC Hospital Association and the DC Primary Care Association. We work closely with the DC Department of Health, now known as DC Health as well. So the report is organized into about this report. The bulk of the report is the findings in the 4 priority areas, and then how do we move forward from here. So when we did a lot of our qualitative work, what we were doing is we were digging deeper into policy and systems changes that could help those 4 areas. So we met with over 100 different organizations across DC. We had input from about 350 different individuals. And when we met with them, either through a structured interview process or a focus group, we were really digging deep into what are some of the policy and systems changes that could help improve these four needs. So this is all described in the report. One of the really nice parts of this project, we had some creative elements as well. We partnered with the Latin American Youth Center in DC to work with 11th and 12th grade children in a Photovoice project. If you're not familiar with what Photovoice is, it's essentially when you ask youth, or anybody, in this case youth, a question, and you ask them to respond through photography. So our question to the youth that we worked with was, how is your mental health impacted by your school and your community? So we had about 10 youth participate. They captured photographs through DC. And the photographs are nice and they're fun to look at, but really what was really compelling to us are the narratives that they wrote. So one of our youth here is saying climate change is mental health today, and she's talking about how her environment is a reflection of mental health today. If you read what the students wrote, it's very compelling. Uh-oh. This is no longer working, so that has the magic touch. Yeah. No, it was working before. Yeah. That's okay. I can go ahead and. Oh, it's not working here either. We're stuck.
Then that sounds hard work. Oh, I think. Do you need to minimize it? See what she was doing.
Working.
Is that where you were?
Yep. And this is working.
I think it froze.
It froze.
Might do that next. I missed this off.
Okay. Exactly. So the second chapter of our report is a landscape of DC. This is where we get into a little bit more of the quantitative information around DC, provide a lot of data on the demographics, who lives where. We look at different communities in DC. So a lot of good information here from more of a quantitative numbers perspective. We have a number of infographics throughout the report as well. This is an infographic that looks at Washington, D.C. as a whole and talks about the race and ethnicity diversity, the age demographics. Importantly, that the overall life expectancy in D.C. is 80.7 years, and the infant mortality rate is 7.1 per 1,000 births. But then the story we really want to tell is that the disparities across the city are vast. And if you look at the wards across D.C., you spend a little bit of time looking at this, you see how wide the differences are. So we've got in Ward 8 in the Anacostia area, life expectancy of 69 years. That's a 17-year difference when you look at Anacostia in Ward 8 compared to Ward 3, where it's 86.1 years. Similarly, look at the infant mortality rate. You see that in Ward 8, it's 14.6 deaths per 1,000 births, whereas in Wards 2 and 3, it's about 2.2. And we just think that this type of disparity, these inequities, are absolutely not acceptable in our city or really anywhere. Oh, it's not that green printed. Just so you know, it's actually very pretty green. It's like a lime green. We spend a lot of time talking about our methods. As I mentioned, we use a mixed methods type of approach. It's a concurrent nested design. And what that really means, maybe some folks in this audience are interested in this type of stuff, is that we definitely look at qualitative and quantitative data, but we let one of the methods drive the other. And we took the opposite approach that many times researchers do, where normally what we do is look at the quantitative data, identify maybe where there's hotspots of disease, burden, and then we go back to our communities and say, well, why do you think this is happening, or what can you do? We actually took the opposite approach. We actually did a lot of qualitative work up front to find out what is of concern to our community stakeholders, documented all of that using pretty structured qualitative methods. It's a method called RITA. If anybody's interested in qualitative research here, it's rapid identification of themes through audio. So we audio all of our interviews, all of our focus groups, we coded all of the data, we produced frequency of themes for our qualitative data. And then concurrently at that time, we're also looking at the quantitative data in terms of disease burden and illness and hotspotting and some of that data, and then merge them together at the end. So this is some of our data sources that we have. So we have each of our findings chapters. So there's a separate chapter on each of the 4 priority areas. This is the mental health chapter that I'm just showing you what it looks like. We have all of the themes that arise from all of our qualitative work identified by the action areas that I mentioned for the mental health chapter. We have quotes throughout the report of what our participants said. I think this is a really nice one here. I'm always baffled by why we can't trust each other and work together. If we do that effectively, then maybe that feeling of trust would come down to our patients, our families, and our communities. This is something that one of our focus group participants said. And when you get the chance to read the full report, you'll see that there is a theme of implicit bias, racism, lack of trust between our communities and our providers, and that's reflected in a lot of the qualitative work that you sometimes find hard to find in the quantitative data. So we wanted to really document that throughout. There's examples of the successes we've had as the collaborative in the past 3 to 6 years of working on these issues throughout the report. And then I'll give you a concrete example as well. I'll give you an example within care coordination. So we met with, like I said, a number of stakeholders across the city. And when I say stakeholders, they were a good number of community-based organizations, government officials, government agencies, social service agencies, asking the same questions about these 4 priority areas. What can we do from a policy and systems perspective to address these areas? One of the things that we heard in the care coordination section, they really wanted providers, hospitals, systems to use technology to help coordinate care. So many of us know with children that we're doing a lot of screening at children, whether it's for depression, anxiety, food insecurity. What we hear from our providers and also from the community is you're doing the screening, but there's a really hard time connecting patients who screen positive to services. So a lot of our community feedback was, you're asking us all these questions, or you're asking my patients all these questions, but I don't have a systematic way of connecting them to resources. So can't we use technology to help this or to help solve this? So as a response to that, since the last needs assessment is still ongoing work, we partnered with the Capital Area Food Bank, who uses a tool called Aunt Bertha. Is anyone here familiar with AnsWorth? I see a lot of nodding heads. It's a resource connection tool, so it's a technology solution to connecting patients to different social services based on what their need is. It's got a nice interface. You type in the need, a map pops up. You get a number of resources in DC. One of the nice things that we were able to do is because we're part of the collaborative of these 5 hospitals and 4 community health centers, Children's itself did not have to pay for the tool on its own. That's part of the benefit of belonging to a collaborative. We worked with the collaborative partners and piloted the tool at 3 different institutions, including Children's. It went well as a pilot. We received pretty good feedback. So as a collaborative, we've now purchased a license for this tool. And not only is it more cost effective because you don't have one institution paying for this, but it's way more collaborative. So we have our community health centers as well as our hospitals working together on the same platform. The idea is down the line that we'd get more hospitals. It would be a citywide platform. We'd be able to track more efficiently did patients use the services we referred them to, what are some of the lessons learned. So those are things we're hoping to get to as we move forward. The next step also is seeing if we can integrate this tool into our EHR as well. So lots of work to be done, but that's just an example of something that the collaborative has been able to do together to help our providers as well as our patients. Very, very bright. Next step. So our next step in all of this work is the needs assessment will be released in June of 2019 by the end of this month. Once it's released, we are required by the patient, by the Affordable Care Act, to also issue a community health improvement plan. So it's not enough that we just identify the needs and document it and make it publicly available, but we need to also say, well, what are we actually going to do about these needs? And that's the exciting part of this work that I feel so fortunate to be in this field is it's not just a report that gets written and sits on a shelf. The idea behind this work is that our community identifies needs, our hospitals then have to invest resources to address those needs. So in some ways, we're shaping and moving what our hospital is investing in based on what's important to the community. I think that's pretty spectacular. Here's a quote from one of our focus group participants. It's not just who is at the table, but how they are brought to the table and how they are engaged at the table. If you invite me to the table, invite me as an equal player, let me help set the agenda. So this is where we are right now, where we have all the findings. This will be released later this month. And we will be bringing back all of our community partners and stakeholders to talk about the synthesis, what the results, but more importantly, what do we do about this collaboratively moving forward? So these are just a couple of the last slides that I have right here. And this is just a snippet of the report. The report itself is probably like 150 pages, but I just pulled out a couple things to show you. I do want to mention that a lot of this type of work, the assessment work, happens across the city. We have DC Health conducting assessments, behavioral health conducting assessments, healthcare finance. We want to make sure that we're very collaborative in this effort. We don't need to be duplicating their work. So the last section of our document is Appendix 2, a scan of assessments. We went through all of the different assessments that we were aware of in the city, the health equity report that DC Health put out, and identified areas where we can partner with these institutions in moving the 4 needs forward. We've already contacted them. They're going to be part of the community health improvement planning process with the idea that we, again, collaborate and reduce redundancy in addressing these needs. I think that's all I have there. Thank you.
Hi everyone, my name is Ankur Shah. I'm a general pediatrician within the Goldberg Center, as well as the medical director of the Impact DC Asthma Program. For those that don't know, Impact DC stands for Improving Pediatric Asthma Care in the District of Columbia. It's a matrix program of research, advocacy, and clinical care, in which a cornerstone of our clinical care program is the Impact DC Asthma Clinic, a one-time interventional asthma clinic that's been shown to reduce morbidity through focused asthma education as well as care coordination. But today I want to talk to you about what we were able to do in terms of create and validate a citywide pediatric asthma registry in the District of Columbia. I've listed some of our co-authors and team members that helped with this project. I have nothing to disclose. This work was actually supported by DC Health as well as EJF Philanthropies. So as background, in DC, we have a prevalence of childhood asthma around 14%. It changes year to year, but around 14%. The prevalence is determined by the CDC behavioral risk factor surveillance system, and it has been pretty consistent for many years, about 14%. The national mean prevalence, though, for other states is around 9%, and that's been relatively constant. So DC has about 40% higher prevalence of asthma. Now, if we think about this geographically, Impact DC actually did smaller survey studies of third-grade classrooms a few years ago in Ward 8, in which the asthma prevalence was around 25 to 30%. So 1 in 4 to 1 in 3 children in a typical third-grade classroom in Ward 8 have a diagnosis of asthma as well. So the prevalence is a little scattered throughout our city. So we know that there is a significant amount higher asthma prevalence in DC. Also, what we do know is there is a disparity in morbidity. For example, similar to what Chaya mentioned about infant mortality as well as early death in different regions in the city, the same is true about asthma morbidity. In Washington, D.C., a child in Ward 8 children in Ward 8 have about 25 times the amount of asthma hospital emergency room visits than children in Ward 3, over 10 times more hospitalizations as well. So we have a significant geographic disparity. But what's interesting also is Children's National is the largest provider of primary, secondary, and tertiary care. This map shows basically all of different Children's National locations, with the red dot being the hospital, this yellow dot on the bottom, United Medical Center Emergency Room, and then the other ones are outpatient centers. So we actually have a good capture across the city. So given that, if the idea is, if we were to take our electronic health records that encompass Cerner, ECW, eClinicalWorks, and Greenway from our primary, secondary, and tertiary care services, we should be able to capture all the children in DC who have asthma and therefore utilize Children's National medical records to create a citywide asthma registry. And that's exactly what our objective was, to create and validate a citywide pediatric asthma registry to support data-driven population level QI projects across the health system. So what do we do? So we actually use, with partnership with the Bear Institute, we utilize data from Cerner. So for those that know, Cerner houses our emergency department, inpatient care, and outpatient subspecialty care electronic health records. We use eClinicalWorks, which is our Goldberg Center primary care electronic health records, and Greenway, which is our Children's Pediatricians and Associates health record as well, another primary care clinic. All those records are housed in a meta cloud of a Healthy Intent data warehouse. So all those records feed into that warehouse, and then we can apply separate algorithms saying we want X or Y to create our registry. So of note, this kind of process of determining who is in our asthma registry took about 9 months. It was a group of clinicians and IT experts really figuring out what is asthma, what are we going to call, what are we going to determine who our asthma population is, what are we going to determine as different indicators. And what I really want to stress is we actually really try to understand our population of children with asthma. For example, in our denominator, in our population, we excluded children with different complex medical conditions or that might have asthma as a subcomponent of other pulmonary illnesses or chronic diseases, because we're really looking for the population of children with straightforward asthma. Likewise, with persistent asthma, so most registries identify ICD-10 codes, so billing codes, that will identify whether a child has persistent asthma or not. But I'm a general pediatrician, and I'm horrible at documentation. So if we're relying on documentation, we're not going to get as much data as we think we should. So we actually use what NHBLI guidelines say persistent asthma should be. For example, guideline-based care says a child should have persistent asthma if they've had recurrent emergency room visits, or severe exacerbations. So we've categorized children as persistent asthma if they've had 2 or more emergency room visits or 1 or more hospitalizations. So we really try to get above the curve. And the idea is all these algorithms would be applied to create a population asthma level attribution, morbidity, quality trends, geomapping, and then compare primary care sites by having attribution. So the question is, well, did it work? And how do we know if it worked? Well, luckily in DC, and again, one thing I want to point out is this could only happen in DC and at Children's National, given our scope. So what we know is the 2017 census estimate says there's about 124,000 children in DC with asthma, and the CDC estimate is about 14%. So if we multiply those two numbers, there's about 17,429 children in DC with asthma, based on the estimate. After the 9 months of work and we use the asthma registry and we pop out our denominator, we have 15,192 children. Therefore, our capture rate of the estimate is about 87.2%. And this is only a 2-year look back. Another way to think about this is Children's National has interacted or cared for nearly 90% of children who have asthma in DC in the past 2 years, because it's only a 2-year look back. So we have incredible reach and opportunity as well. So what we're able to show is this graph actually shows asthma-related emergency room visits from 2016, 2017, and 2018 using our asthma registry. We see around 3,100 to nearly 2,700. However, these are absolute numbers, but what's great about the asthma registry is that we have a denominator, so we can actually talk about at-risk rates. 20% of children who have asthma had an ED visit in 2016 versus 17,000 in 2018. The same we could do for hospitalizations. So this is a graph of individual asthma-related inpatient hospitalizations at Children's National from 2016, 17, and 18. As you can see, the hospitalizations decreased from 623 to 519, but we also have a percentage. About 4% of children had a hospitalization in 2016 compared to 3.4% in 2018. I do not want to put too much stock into. It is great that we're seeing a slight decrease, as you saw in these last 2 graphs. I think over the next couple of years, we'll see if that trend continues. There are a lot of external factors relating to asthma exacerbations. H1N1 is a perfect example. If you were to see it, kind of spikes up. So I think this is promising, and we'll continue to see it. So we're able to see population level trends. Also, by zip code, we're able to real-time map where our families live and the kids live that have these asthma exacerbations. So this is just from 2018, a distribution of asthma ED visits. The larger and darker the circle, the more patients there are. And as you can see, it's centered around Ward 7 and 8, as well as the Georgia Avenue corridor, which we've been seeing a little bit more of as well. And we're able to transfer from 2016 to 18, seeing how those trends change. What's great is I can click on that circle and see who the kids are. We always say, the CDC said there were about 15,000, 17,000 children in DC with asthma. With this, we could tell the CDC, do you want to know their names, addresses, how they utilize the health system. Like, that's the power that this registry has. We can actually know who these numbers are and really bring them into care. So this graph shows on the y-axis is the number of emergency department asthma-related ED visits, and each bar is an individual patient. The different colors stand for different years. So for example, this one bar over 2018, 17, and 16 had over 27 ER visits. And actually, this is a patient, if you'd indulge me, I want to talk about. In last August, we identified this child and saw this child in the asthma registry, knew this child in pulmonary clinic, and care coordination, My Help GPS, actually brought this child to our attention. So all around the same time, we saw this family. And this family was well connected, had a pulmonary medical home as well, but very disjointed care between the school health system, between their medical home and their actual home as well. And the child had over 40 to 50 missed school days in the previous year. What we were able to do was we brought everyone together. Their primary care pediatrician, who's from Mary Center, their primary pulmonologist, their insurance case manager, their My Health GPS care coordinator, their 504 plan coordinator from DC Public Schools, their school nurse, and the family to get a specific plan tailored just to this child to see how they would interact at school, at home, and within the health system. And there was a lot of misinformation or a lot of confusion around that. Since then, this child's life has been transformed, significantly reduced missed school days, significantly reduced emergency room visits. The green is 2019. We actually reduced it so much so that the family was able to get so coordinated care, and everyone understood what's happening with the child's asthma as well. And the pulmonary, and very much kudos to Dr. Klein, the pulmonologist, who really just went forward and had very coordinated and aggressive management. So that's the power that this could provide. Likewise, we're able to attribute to different primary care clinics based on not on what's on their insurance card, but actually which clinic they visit the most often. So this is an example of 3 different clinics in which you have different attributions of patients. Tells you how many ED visits of those patients and the percentage, hospitalizations, who have persistent asthma, and then actually prescription of controller medication, which, if there's a variation, that's a perfect point for quality improvement efforts as well. So that is where we are at, but there are some limitations of our approach. One is it's all based on estimates. We have a 2017 census estimate based on the 2010 census. The behavioral risk factor surveillance system is a survey system as well. So we're assuming we have a good capture based on that estimate. Also, everything's related to the quality of data in the electronic health record. Throughout this past year, we've had to recalibrate some measures as well as data changes, as algorithms change. So it's never perfect as with any administrative data. But our hope for the future directions is really thinking about the highest risk kids with asthma, the children at risk of death, the children with recurrent hospitalizations, and trying to identify who they are, bring them into care, solve gaps of care, integration with the school health system and children's school services, thinking about a predictive model. So the idea is if a child had an emergency room or hospitalization in September of 2016, September of 2017, September of 2018, what are we going to do in August of 2019? Is this an opportunity where we can prevent something? And then have the ability to apply this to other areas as well. And luckily, DC Health is continuing to support us in this project, so has support through October and probably for the next fiscal year as well, which is exciting. And if anyone is interested in working with us with asthma registry, please let me know. And this is the team is very large. We have a lot of people working on it, with specifically the validation efforts. Deborah Quint, for those who remember, previous director of Impact DC, Gia Ravi, who's from the Bear Institute, Mark Weiss and Brian Jacobs team teach as well. And that's it. Happy to chat more about it later. Thank you. I'll introduce Dr. Sharon Singh.
afternoon, everyone. My name is Sharon Singh, and I am a clinical psychologist with the Healthy Steps team at the ARC. So today I just wanted to talk to you all about the Healthy Steps program, give a little bit of background about it nationally, how we've been implementing it here in DC for the past 2.5 to 3 years, and highlight some of our research questions, and then talk about some of our next steps that we have. So I should have mentioned that the Healthy Steps team is in 2 locations here in DC and Southeast, one in Anacostia and one at the ARC. And in terms of so it's a national program, but here more specifically at Children's, it is hubbed under the Early Childhood Innovative Network. And does anyone know what that group does here at Children's? Yes, I know some people do. So it is a collaboration of an amazing group of individuals, health and education providers, community-based organizations and advocates, as well as researchers. And so we all work together for this mission that we very much strongly believe in. And so Healthy Steps, like I said, is a national model, and it has been in the U.S. for about 10 years. And it started in Montefiore, New York, and it is essentially embedding a child development specialist into primary care. And so across the United States, there are 120 Healthy Steps sites in family medicine and in pediatric medicine. The Healthy Steps specialist, like I said, is a child development specialist. Interestingly enough, here in DC, for the 2 sites, all of us are psychologists randomly, but nationwide they can be under many disciplines, a social worker, even a nurse practitioner. So they really vary in discipline. And so in terms of our model, this is kind of the backbone of it. We take a very much a team-based approach, and I'll tell you a little bit more about the team, but typically for any family, there can be up to about 5 providers supporting the family. And the way that we support families are in many, many, many different ways. We provide surveillance around child development and anything related to child development, really. So if a family has questions about child development, concerns, they want to know how to strengthen their child's development, like specific activities to do. They have questions around eating, sleeping, behavior. We are there to support them. We also provide surveillance around the social determinants of health. So if a family is in need of food or anything related to being able to care for their family, we provide that kind of support and that kind of care coordination with our team. We do connect our families to community resources, of course, and we really provide a warm handoff. So instead of saying, like, here's a number you can call to get a new crib, we're really doing, I think, a great job of connecting the family to these resources, looking it up, making sure the number works, making sure that what they need is there, and then calling the family back, letting them know, just in case if we didn't know if it was there or not, and really making sure that they are connected to what they need. And we're using our pediatricians. I have the honor of working with Dr. Shah, and we all have to really do this together. And so embedded in the Healthy Steps team is myself, a Healthy Steps specialist. I also work with a family service associate at the ARC, and she helps support the care coordination around early intervention as well as other social determinants of health. She and I work very closely with the pediatrician. as well as a clinic champion. So a clinic champion is a pediatrician who helps create the buy-in of the program within the clinic. So it's really all of us working together. And so the Healthy Steps model, this is some not that much data, but some data from the Healthy Steps National Office Site Performance Evaluation. This is back in 2015. And as you can see, embedding someone like myself has really, really, really significant impact on our families that we serve every day. And so this specific evaluation shows that families are 1 to 2.5 times more likely to attend the well child visit on time. At the specific time points, they're more likely to receive their vaccinations, and they are less likely to go to the ED for non-urgent visits. All right, and so I've already mentioned this, that the Healthy Steps team started in Anacostia in November of 2016. At that time, there were 2 part-time Healthy Steps specialists and 1 family service associate who was there full-time to support them. And the Healthy Steps team over at the ARC started in July of 2017. That's when I started. And I started part-time, and now I'm there full-time. So you can see that we are growing. So the exciting part is that now over at Anacostia, there's going to be 1 full-time Healthy Steps specialist. I am now full-time over at the ARC. We have also been written into the legislation, and so let me make sure I get this right. So provisions to the Birth to 3 Act included monies to expand Healthy Steps to 2 additional sites in DC, which is pretty amazing. We also are going to be, or have recently added neighborhood family champions. So these are 2 women who will provide peer support in the community, and they're really our eyes and ears in the community to be able to let us know how things are going, what else may be needed, what needs to be changed. So we're excited to have both of them on our team as well. And these are just some of the members of our team. Between the 2 sites, you can see we're a large group. And so Healthy Steps in a nutshell. We are serving families 0 to 5. What's interesting, like I had mentioned before, about the Healthy Steps team here in DC is that we are all psychologists. And so the psychologists over at Anacostia, when they started in 2016, really realized that we are supporting children and families, but more importantly, we really need to support our parents. And so through the well child visit, the moms of newborns at certain time points are given a measure to assess for postpartum depression. And so part of our innovation through Healthy Steps is to continue that surveillance past the point that the clinic does. So to continue to see how the moms are doing in terms of postpartum depression, and to really provide a warm handoff if they want to be connected to places in the community where there aren't actually too many to send them to. And so we as clinicians can provide that kind of support to our moms, and so we can set them up with us to have sessions with us to talk about how they've been doing, and really provide that as early as that same week or that following week. In terms of our approach, as you can see, I'm only one person within the clinic, and I'm very busy. And so in order to best serve our families, families. Families that need more, have more needs, are given an indication of intensive in ECW, and then families who have been doing well, coasting, don't really have as many needs, are identified as global. Those can be interchangeable, which we are starting to capture to see how many families are going from global to intensive, perhaps when things are brought up, and we're looking deeper into what's going on with the family. And we're also definitely want to be able to see that the families go from intensive to global. And so that is something that we'll be looking at in the future. We have many projects and pilots, so I'm happy to talk to anyone about those. Some of our projects have, one of my most favorite ones is the collaboration between Healthy Steps and early intervention. So we are meeting with Strong Start here in DC as well as early stages to really be able to serve our families the best. And that is one of our research questions too. One of my other favorites is a collaboration that we have with the DC Diaper Bank. And so being able to work with the DC Diaper Bank and get diapers for families and be able to give those out during the time that they're in clinic. And so these are some of our research questions. We're assessing the extent to which Healthy Steps improve identification of child development and parental mental health concerns. We do want to know, does Healthy Steps improve the linkage of families to early intervention? And that's not only did they, were they called from Strong Start to make an appointment. It is to go even kind of deeper and see if the family was able to have an evaluation with them. The next question is Healthy Steps effective in reducing at-risk parent depressive symptoms? So looking at the EPDS 1 year out and seeing the reduction of the symptoms of depression and seeing if Healthy Steps has been able to reduce how much more we're able to help reduce those symptoms. And then finally, we want to gain perspective from our providers that we're working very closely with. So we've performed one kind of evaluation to look at what are the providers thinking about us in terms of how we are implementing Healthy Steps in clinic, and what could we do better, what's working, what's not working, what else do we need in clinic. And so just a little bit more data. We recently presented at PAS, and we had a poster about parental mental health in a pediatric care setting. And 36% of the 450 families that we saw in 2018 that were seen by us and screened in clinic scored positive for depression and anxiety. And 23% of our work outside of the well child visit, so when families came back to see us, were around parental mental health, parental stress, parental anxiety, and parental depression. So there is a need. And 94% of the providers reported that Healthy Steps had increased their capacity to address parental mental health within clinic. So that's pretty amazing. And so we are not only working with our families, but also working with our providers to educate them in terms of how to better approach families when there is something going on in terms of the family's mental health or even stress, and how to reduce that stress. And quickly, I know my time is up, but I had a mom last week who had elevated EPDSs up until 6 months. We will see, up until 4 months. We'll see how she's doing at the 6-month mark. We met, and at the end of the session, we did deep breathing. I guided her through some deep breathing, which was also new for me. And at the end, she was like, "That was awesome. I'm going to try this at home." And then it was sort of spiraled from there positively. And she was like, "Maybe I can pair this with yoga." So we are trying some different ways of integrating a mental health classic intervention. We're trying innovative ways to figure out how to empower families to reduce that anxiety, reduce that depression, reduce that stress themselves. So that's it.
I'm popping up. I'm Dr. Young, the Associate Director of the Center for Translational Research, and we have 10 minutes left, which is perfect. We held questions until the end, so I'm going to ask those in the room that have questions for our panelists. Now is the time. In the back first.
Great work that you're doing. I have a question about the Healthy Steps program. You said that there's some questions around like eating and nutrition. Can you elaborate on it? That's my area of interest. But can you let me know what kinds of questions and what do you do for helping them in your eating?
Maybe not so much nutrition, but definitely some more education around nutrition. So I think the first thing that comes to mind is being able to decrease the amount of milk a child is drinking, for example. So like I worked with a team with a young one who, I think he was 18 months, and he was drinking like half a gallon to a gallon of milk a day. So it was too much. And so the pediatrician and I worked together to figure out like a plan in terms of how to approach this dad about how to decrease that, because this child did not want to drink anything else besides milk and would just throw a fit if he didn't get the milk. And so behaviorally and from a nutrition point of view, like educating him about, why we shouldn't have that much milk, and, the pediatrician and I can let them, talk about medically what happens, but then talking to the mom and dad. So I have a meeting set up with the mom and dad, a conference call, because they aren't able to come into clinic to talk about like the action plan to reduce this child's milk. So that, for example, is something that we would do together in clinic.
Yeah, I think nutrition is a really behavioral piece of the puzzle. So I think Healthy Steps is a really great way to address that for a wide number of nutritional problems.
And then just in general, like how can I get my toddler to try different foods, or more foods? Like the child is eating, just like 3 or 4 foods, and it's becoming a problem at daycare and at home, and so, really being able to empower families in terms of how to do that, and then they're able to call me anytime in between well-child visits as well. And so I do set up a lot of telephone conversations with families around how to support them and be able to meet their needs.
I'm sensing a collaboration. An expansion. Go ahead, Dr. Robbins.
So going back to Chada's point that one of the biggest issues in mental health care and the fact that right now so many people graduate from school horribly in debt and come and work at Children's National and a community mental health center is not going to pay your loan off. And psychiatry actually doesn't qualify for loan repayment, even though we all went to medical school too. How you can convince as part of the bill that loan repayment for mental health care practitioners, whether they're psychiatrists, psychologists, or social workers, would be one way to meet the need and erase the debt. You then get young, well-educated people who were invested in this mission and could afford to stay. I mean, we've had to struggle very valiantly trying to get people to stay in academics when they can go to Chevy Chase, make 3 times as much, and pay their loans off.
I think that's a perfect example of the type of CHIP, the Community Health Improvement Plan strategy, that we could formulate with all of the partners across the city. Is however we have in the Community Health Improvement Plan process, it's not just children advocating for different legislative or regulatory or any kind of systems change, but we have 5 hospitals across the city, as well as support from the DC Hospital Association. So those are the types of things when we come together to develop the Community Health Improvement Plan could certainly become one of the strategies. In general, not just even as part of the needs assessment, but many people know in children, we have community health priorities as part of our strategic plan in children, and mental health is one of them, and Ellie and I work on that work group together. And there's certainly a focus and interest in increasing reimbursement for services, advocating for exactly what you're talking about. There's a lot of energy in that area. Thank you.
Well, that's,
Yes.
okay.
And then the big boss.
My question is very, very quick. You're targeting children from 0 to 7 age. But what happens to them after 5? Do they transition to public school system or another system to follow them or the longest?
That's a great question. In the time that I've been a healthy step specialist, we've vacillated between serving families 0 to 3, 0 to 5, and, it's so anecdotally, from the time that we started, if there is a child who is perhaps older out of that range, we will support them. But there's no mechanism in place to carry on that past, the age of 5 or 6. We'll help. I'll help any family, and I know my colleagues will too if the child is older. But yes, it is almost like DCPS will take over or the school system that they're in. We're still there to support them, if needed, but it's not part of Healthy Steps per se.
My second part question is shorter than that. We are following the same pattern that you've seen in with depression. We follow the postpartum moms in the NICU. Same numbers, almost third of them have defined questionnaires that puts them in the category of postpartum depression. I wanted to see if you, as well as us, have a mechanism if they're depressed enough to find out that they may be suicidal, maybe hurting themselves or others. Is there a mechanism to support them with
So we're actually,
transfer of
I'm going to answer that question. So hospital-wide, as per the Joint Commission mandate, we are rolling out the Columbia Suicide Severity Rating Scale. There is already available in the wonderful Cornerstone, the education module of how to do a screening and an assessment using the Columbia, which is normed from 6 to 95. So if your nurses or whoever's doing the screening in your setting is interested in being trained on that, we can speak offline about that. Okay?
Thank you so much.
Thank you.
Wonderful presentation.
So I think this is incredibly exciting. And I think that, to sort of have this really permeate the system, here in DC is terrific, although it's not circumscribed, as we were just talking about, in age groups. And then to template this into other cities and other domains. A couple of things strike me. Number one, it's resource, right? And so everybody wants resources. But number two, I think there's an incredible opportunity to think about the efficiencies of what we do. You made the point that you can spend time with a family that's identified as having stress in their lives, being poor is being stressed, right? Stress in their lives, anxiety, true mental health issues, et cetera, et cetera. And that you, in a sense, become an extension of what is a well-child check because of the context of the family. One thing that I'm wondering, and Chad, I would love for us to think about this collectively, is to think about the power of data in terms of how, the slide that you show, that one child who went, let's just leave 2019 a little bit, 2016 versus 2018, number of ER visits, because people were brought together. If we could think about the power of some of the resources we have here, and obviously, I'm thinking about the CTSA and informatics, to sort of collect these data, to collect impact data, to be able to show DC, doing these kinds of things makes a difference. And even to sort of present an economic model that would push people to say, not only is it the right thing to do, because for some crazy reason, people don't do things because it's the right thing to do. It's not only the right thing to do, but it would be really cost effective, and these children's lives would be turned around. This might be something that would be a good marriage between this incredible portfolio of programs and the CTSA and the power of the informatics within the CTSA. Because I'm thinking about Laura's point. I mean, how many pediatricians really know about nutrition? And if they do, how many of them have time to really talk about it? I mean, yeah, a gallon of milk a day is too much. We all know that. But how much what kind of calories should we think about, and how could we develop programs that could be very efficient in conveying information? I mean, I think these are really, really cool things. And this might be, given the platform you guys have put together, the right place and the right time to do it. I mean, congratulations, the impact you are having on the lives of children is fantastic.
Well, there's no better note to end on.